Good evening, everyone. On behalf of Saudi Society for a Blood Disorder, I would like to welcome all of you to our update Hemophilia management meeting. My name is Dr. Ahud Kashari. I'm a pediatric hemato-oncologist in East Jeddah General Hospital, and I'm also the Vice Dean of the Academic and Training Affairs. I would like to express my gratitude to the Saudi Society for a Blood Disorder for inviting me today to be a moderator to this meeting, in particular Dr. Al-Fareh and Dr. Tarawa. I would also like to thank Takeda for their great sponsorship. We are thrilled to have such an excellent speaker and also a good number of attendees today. And we strive to make this meeting as enjoyable and informative as possible for everyone. And we ask everyone that who has a question to put his question in Q&A box. At the end, we will go over it. Please be aware this meeting will be recorded, and also now I would like to turn your attention to the program that divided to three main parts. Our first speaker, I'm delighted to introduce Dr. Carmen Escariola Ethenhausen. Dr. Carmen is a director of Hemophilia Center Rhein-Main in Frankfurt, Germany, and her research interests are the hemorrhagic disorder, particularly in treatment of hemophilia and management with inhibitor. She also has numerous publications, and she's an active member of many international society of thrombosis and hemostasis, such as ISTH, an international prophylaxis study group, and other working group focused on treatment of hemophilia. She will talk about pegulation and extended product and safety aspect in pediatric population. So welcome, Dr. Carmen. The floor is now yours.
Thank you very much, Dr. Kashari, for this warm welcome, and good evening, colleagues, ladies and gentlemen. I'm really proud to be invited here to your Saudi Society for Blood Disorders conference, which is currently taking place virtually. So I will start to share the screen. So as Dr. Kashari already mentioned, I'm going to talk about pegulation in extended half-life products and safety aspects, focusing on the pediatric population. As you already know, I'm a pediatrician by training, and so the treatment of pediatric patients, of hemophiliacs pediatric patients, should be in the focus of interest here. These are my disclosures. So I think I do not have to tell you that Factorate concentrates are cornerstones in the treatment of hemophilia. They are universal agents because we can use it to treat acute bleeds. We can use them to cover surgery or invasive procedures. And of course, we can use them for prophylactic purposes to prevent bleeds and consecutive arthropathy. We can monitor Factorate concentrates using standard methods, which are usually the one-stage assays. We can adapt treatment intensity according to the clinical needs. This is particularly important when we treat bleeds or when we cover surgery, but this is also of importance when we individualize prophylaxis. So in the focus of the treatment nowadays, extended recombinant half-life products are in the focus of interest. Why extended half-life products? Because they have certain properties compared to the standard half-life products. What you can see here that in addition to half-life prolongation, we have to face the fact that the area under the curve is significantly higher than with the standard products. We can also achieve higher trough levels, which may be important for subclinical and spontaneous bleed prevention. We can achieve peaks, which are important to protect the patient from bleeds during physical activity. And as I already mentioned, due to the higher area under the curve, there is a higher factorate activity over time compared with standard half-life concentrates, and therefore better protect patients. So we have the opportunity to optimize peaks, troughs, and area under the curve through a personalized approach, which is very important. And particularly these extended half-life products allow a high degree of individualization, which means that we can go for higher trough levels, that we can go also for a longer administration interval, but we can go for a higher protection and a better bleed prevention. So there are different strategies to extend the half-life of recombinant factor 8 or factor 9, which include an altered protein structure, the fusion with other proteins, such as albumin or the FC fragment or the von Willebrand fragments. Polypeptide extension is also possible, or the covalent attachment of moieties, such as PSA extant, and in the focus of this presentation, the pegulation. And here you can see the different factor 8 and factor 9 products and the different half-life extension methods, which led to a half-life extension. We know that this is particularly true for all factor 9 products, but also for the factor 8 products, we have a substantial prolongation between 1.4 up to 1.7-fold half-life extension. So the focus is on the pegulation of extended half-life factor 8 products during my talk. And what we have to state is that pegulation is a well-established technology that extends half-life without compromising its biological activity. So pegulation involves the attachment of a hydrophilic macromolecule to the parent, which is the recombinant factor 8. As I already mentioned, it optimizes the biological activity of the factor 8 molecule, but it does not alter the biological activity. It shields recombinant factor 8 from natural clearance pathways and thereby extending its half-life. So pegulation has been performed for almost 30 years now. And you can see that the first pegulated biopharmaceutical was licensed in the 90s. There are more than 20 pegulated drugs in development and 14 FDA or EMA approved pegulated biopharmaceuticals commercially available for the humans across the EU and the US. What is very important that the safety data, and this includes safety data gained from studies as well as from real world, indicate no safety concerns associated with PEG at clinically relevant dose levels. But what is PEG? PEG is an abbreviation for polyethylene glycol, and this is a chemically almost inert, not charged molecule. It therefore has a low chemical reactivity. Peter Turacek, who is an expert on this, calls the PEG molecule a lazy molecule. What does it mean? A lazy molecule does not want to interfere with other molecules. So in conclusion, this means that it does not want to interfere with any sites in the body of a patient, and that it does not change any other molecules. We have to know that it is an M5 philic polymer, so it can be hydrophilic as well as hydrophobe. It can vary in size, which is defined in kilodalton, so from less than 1 kilodalton to more than 100 kilodalton, and the size of the PEG, I will talk about this later on, is extremely important when we talk about clearance. So PEG is widely used. I just mentioned its use in pharmaceutical components, but it is also used in everyday consumer products, such as toothpaste, shampoos, soaps, detergents, moisturizers, hair dyes, deodorants, and so on. So therefore, to be exposed to PEG is extremely likely for all of us, including our patients, out of the treatment of Factorate. What is less well recognized, but I want to emphasize here, is that PEG is an excipient in many unmodified factor concentrates. And this is shown here. So PEG is a component of the reconstitution material. It is not bound or attached to the Factorate molecule, but you can see here the different concentrates and the blue bars, which show us that a considerable amount of PEG is given to a single patient if he is using these mainly standard half-life products. And this affects both. It affects plasma-derived as well as recombinant products. By the way, this is also true for other products, such as here immunoglobulins, but what you can see here that there are also products where the PEG is attached to the Factorate molecule, and this leads to a half-life extension, such as in Dinovate or here in Factor 9, Refixia. What is extremely important, pegulation is the covalent binding of one or more PEG molecules to another molecule. In this case, it is Factorate. And how does it extend half-life? Well, the first step with its binding to the Factorate is it increases the size of the modified molecule here, Factorate, and reduces the renal elimination. So we have a reduced elimination. In addition, we have a lower clearance due to a reduced receptor-mediated clearance. We have a prolonged retention in the circulation, and potentially, this is discussed, potentially a reduced immunogenicity due to the steric shielding by PEG and the water molecules. So the big question is, how is PEG physiologically eliminated? And this occurs mainly via renal clearance. This is the most common route of excretion, particularly for small, but also for large unconjugated PEG molecules. What is also important to know that the renal clearance is significantly driven by the size of the PEG molecule. So the clearance is slower for non-conjugated PEG molecules with a size of more than 30 kilodalton. What is also very important to know, if you repeatedly administer pegulated products, is there an accumulation to indefinitely? No, this is not the case. So after a saturation phase, an accumulation phase, you achieve the so-called steady state. And this steady state means that the amount of the drug in the body will rise until the rate of clearance equals the rate of administration. And this is what we see here. What of course happens if we stop the treatment, the compound will be cleared from the body over time. So I already mentioned that renal and partially also the elimination over the liver is of importance. However, PEG can also be eliminated or stored in the phagocytic cells via vaculation. This is a normal physiological mechanism for the removal of a foreign body. You can see here that the PEG molecules are endocytized into the cells and then excreted without any modification. I just want to remind you that the PEG molecule is a lazy molecule, which does not want to interact and to react in the cell. It is excreted without any changes. What is also very important is that vaculation occurs as an adaptive response if a certain amount of PEG administration occurs. And what is also important, even if vaculation occurs, adverse effects on organ function do not commonly occur. But the big question is, when does vaculation occur? And this is mainly dependent on the drug dose as well as the molecular weight of the PEG itself. So according to a publication by the EMA CHMP review, it has been shown that PEG molecules with a size above 30 kilodalton exhibit a slow renal elimination and correspondingly have a greater potential to accumulate within the cells. However, we have to face the following facts. The studies of accumulation are focused on studies conducted in cynomolgus monkeys with PEG molecules with a size above 40 kilodalton, a study duration of more than 6 weeks, and a monthly PEG exposure of more than 0.4 micromole per kilogram. You may say, well, okay, what does this mean? 0.4 micromole per kilogram. How does this correlate with, let's say, standard administration in patients? And for an example, I show you here the PEG exposure with Rurioctococc alpha Pegol, which is a dinovate in the setting of prophylaxis and also during surgery, and particularly during surgery, we have a short-term high dose administration of Factorate. And you can see here the PEG exposure per month is 0.0028 for conventional prophylactic treatment and 0.014 for more intensive treatment in the setting of surgery, and is therefore far away from the threshold for concern of vacuolation. In conclusion, we can say if we administer this PEG at standard doses and not at extremely high doses as it had been given to those animals, we never reach the threshold, and the PEG is, without modifications, eliminated by the kidney. So, which products are available? I would shortly like to introduce you the 3 pegulated Factorate products. So this is Esperoct N8GP, also known as Turoctococc alpha pegol, which is a B-domain truncated recombinant Factorate, which is with a single branch 40 kilodalton PEG moiety. Once upon Factorate is activated by thrombin, the truncated B domain with the attached PEG molecule is cleaved, and Factorate is ready to work for the coagulation. There were no safety issues in clinical trials in adults, but I will show you later on also in pediatric patients. GV, also known as Damoctococc alpha pegol, is a B-domain deleted recombinant Factorate with a single branch 60 kilodalton PEG moiety. So here we have even a larger PEG moiety. So what is particular to this recombinant B-domain deleted product is that there is special linker to an engineered cysteine amino acid in the A3 domain of Factorate. This mutation, this modification became necessary in order to be able to attach this 60 kilodalton PEG molecule. So therefore, we have here a B-domain deleted mutation, which is pegulated. And then we have Dinovate Turoctococc alpha pegol. And in contrast to the 2 former products, we are talking about a full-length recombinant Factorate and a very well-known full-length Factorate, which is Advate. And to this Advate molecule, a 20 kilodalton branched PEG has been attached and caused or induced is better half-life prolongation for this product. So in conclusion, these products, including the FC fusion recombinant product, are licensed for prophylaxis and for the treatment of bleeds and surgery. However, they have different dose recommendation and regimen, which supports the ability to individualize Factorate prophylaxis for the unique patient. I don't want to go very deeply, but roughly around 50 units per kilogram body weight are given twice weekly. For some products, the administration interval can be prolonged, but we have to face the fact that then the trough level decreases. Particularly a Dinovate has a high potential of individualization. I think you all know the results of the PK guided study, the Propel study, which compared the outcome after inducing different trough levels, traditional trough levels 1 to 3%, and higher trough levels 10 to 12%. So which clinical data do we know? And here I will focus very briefly on the published data from the licensure study for an N8GP. In total, 68 PTPs below 12 years. It was a mixed group, less than 12 years, less than 6 years. So the traditional study, the way of studies are conducted in order to license such a product. The product has been given twice weekly, and there was an overall estimated ABR of 1.08, in median 0.81. This study was conducted for almost 5 years per patient, and 56% had 0 bleeds in the 4th year of exposure, and 86% had zero spontaneous bleeds. All target joints have been resolved. So this is a typical attribute for the use of extended half-life products. Concerning the safety parameters, we have to state the fact that no Factorate inhibitor development was observed in these PTPs. About 1/3 of the patients were tested positive for anti-PEG antibodies prior to the first exposure to this product, but also during the study. But I already told you that PEG is everywhere, and that PEG exposure occurs even out of the use of Factorate. What is very important to mention is that those anti-PEG antibodies were not shown to affect Factorate activity or treatment response. If we focus on the AEs, we see a typical AE profile of all Factorate products. This is also true for the SAEs or the MACI, the so-called medical events of special interest, which was not something extraordinary. If we look at the data with GV, the B domain deleted 60 kilodalton branch pegulated product, we can see 61 PTPs less than 12 years. Prophylaxis was tailored according to the patient needs, given twice weekly, every 5 days or every 7 days. And we can see here a low occurrence of bleeds, a low annual bleed rate, 2.9 respectively 2.4 in the second part of the study. The median ABR for joint bleeds was 0, and most bleeds could be treated with less or 2 infusions. What about the safety profile of this product? No patients developed an inhibitor against Factorate. 8 patients withdrew from the study because of suspected immunological response against PEG, which occurred within the 4 days. So these were 3 children with hypersensitivity symptoms. 5 showed loss of efficacy. There was no major safety concerns in these patients, and all patients resumed their prior Factorate treatment at the same dose and frequency as before the study. What about the Rurioctococc alpha, a Dinovate product? And once again, here the data from the pediatric studies, patients less than 12 years. You can see here the ABR, which occurred with a standard half-life product, if this has been done 2 times weekly compared to 2 times weekly of the extended half-life product Dinovate. And you can see a substantial decrease to 2 bleeds per year for the twice weekly regimen, and 0 for the 3-time weekly regimen, which of course increases the trough level for these patients. Which is the most beneficial treatment approach? I think this should be based on an individualized decision, including PK, even for children, including population-based PK. If we look at the prophylaxis efficacy in those patients, you can see that in median there was 2.0 bleeds for all bleeds per year. The ABR for spontaneous bleeds was in median 0. This was also true for the joint bleeds, and 1.8 for injury-related bleeds per year. If we look at the patients who had 0 bleeds, we can say 92% had no target joint bleeds, 73% had no joint bleeds, 67% had no spontaneous bleeds, and 38% no bleeds at all. What is also remarkable that those patients who started in the study with a target joint, that during the study phase, all target joints could be resolved. If we look at safety with Rurioctococc alpha pegol, there was no inhibitor development against Factorate in this previously treated cohort. As a secondary endpoint, if we are looking to binding antibodies, there were 5 patients where anti-PEG Factorate IgG antibodies could be shown, in some patients transient, in some patients at study completion, and in other patients they were sporadically apparent. Once again, these anti-PEG Factorate IgG antibodies had no impact on hemostatic efficacy or safety in these patients. And if we look at the AEs, the occurrence and the type of AEs, they were comparable to the safety profile of other extended half-life and standard half-life products we already know. So I want to sum up and to conclude, pegylation technology has been clinically used over 2 decades, almost 3 decades, and leads, in the case of the attachment to recombinant Factorate, to a 1.4 to 1.6-fold half-life prolongations. So what we have to take into account that we have different PEG molecules of different sizes, which are used for this half-life prolongation and which are excreted in a different fashion. However, if we look at the study data, and I also can include the data from its yearly clinical use in many countries worldwide, all pegulated Factorate products revealed a high efficacy and safety in both adult as well pediatric patients. And I think accordingly, the WFH recommendations for the treatment of people, also children with hemophilia, they state clearly that clotting factor concentrates are the treatment of choice for people with hemophilia, as they are very safe and effective for the treatment and the prevention of bleeds. And for hemophilia A and B patients, there is no evidence for any clinical safety issue in persons with hemophilia to recommend a preference among the various mechanisms of action. And this includes pegylation, Fc fusion, and albumin fusion, which are technologies to extend half-life in those concentrates. And with that, I want to thank you for your attention, and I'm ready to take questions. However, I think the presentation will be discussed afterwards in the panel. Thank you so much.
Thank you, Dr. Carmen, for this amazing and outstanding presentation. Just a reminder to everyone that we will keep the question to the end, and you can write it in the Q&A box. And now we will move to our next speaker. And I'm pleased to introduce Dr. Ahmed Tarawa. Dr. Ahmed Tarawa is a pediatric hemato-oncologist at King Abdullah Medical City in Al-Madinah Al-Munawwara. And he served as a mentor for most of us as a pediatric hematologist. He's a president of Middle East and North Africa Hematology League. Also, he's a board member of Saudi Society for Blood Disorders. And he will give a talk about a prophylaxis personalization. Welcome, Dr. Tarawa. Hello, Dr. Tarawa.
Thank you, Ahoud. I was muted. Sorry for that. Thank you, Ahoud, for this kind introduction. Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. It's a great pleasure to share people this evening of hemophilia. So now I'll take you to another issue in hemophilia where prophylaxis we want to make the prophylaxis personalized for each patient, and probably over the last 10 years we do speak about it till came into the recommendation in the World Federation of Hemophilia 2020. Let's go ahead. Okay, sorry guys, yeah. So let me start to explain what is hemophilia. Hemophilia A, which is factor 8 deficiency, and hemophilia B, which is factor 9 deficiency, and both of them inherited as X-linked recessive disorders. So it does affect boys only. And ladies, they are carrier, they are not suffering of bleeding like boys, but they suffer from other bleeding issues like menstruation, heavy menstruation or so. Hemophilia A is more common than hemophilia B with an incidence of 1 in 5,000 to 10,000, while hemophilia B, it is 1 in 25,000. And usually those patients, they will present with spontaneous bleeding, particularly in joints and muscles. And for the treatment, they need to be on replacement therapy with factor 8 or 9 concentrates, and most problematic and catastrophic issues, nightmares for the healthcare provider, is inhibitor development. We divide hemophilias into severe, moderate, and mild based on the factor 8 or factor 9 activity. Less than 1% they are severe, more than 5% they are mild, and 1 to 5 they are moderate. Those patients with severe hemophilia, usually they do bleed spontaneously. What is the rationale behind the prophylaxis? By the way, prophylaxis has been used in hemophilia patients for the last 50 years. And the rationale was those patients whom they are mild hemophilia, they don't bleed, while those with severe hemophilia, they do bleed, and the moderate hemophilia in the middle. So why not to transform the severe hemophilia into moderate type of hemophilia by increasing the factor, as far the factor issue is the most important one. So people, they tested this rationale, and they have found that those patients, they are doing much better than those patients whom they are not on prophylaxis. The aim was to maintain the health of the joint and to have zero joint bleed. But currently we do have another aim where we don't want them to bleed. We want them to go into normal life. When we talk about personalization of the prophylaxis based on the BK guided type, this is based on some studies where they have shown that people, they are different when they have injected with factor 8 or 9. So the clearance, volume of distribution, and so is different from somebody to another based on multiple factors. In this slide, it shows that the lifestyle of people, it does make difference. Those whom they are working in an office setting are so different from those they are doing some type of the sport. Children different from the elders. So each one of them have his own function with factor 8, so they need different doses, different frequencies based on this factor only. Three determinant for the optimizing of prophylaxis, as you can, we are using the word optimizing rather than optimal or optimized prophylaxis. To date, we couldn't reach the optimum prophylaxis, and we do not know exactly what is the definition of optimum prophylaxis. But we are trying the best to have optimized prophylaxis. So trough level, one of the determinants of the optimization of the prophylaxis based on the treatment type, dose, interval, cost, availability, and so on. How bad is the joint, bleeding, arthropathies, physical activities, I said, if there is chronic synovitis, and how many bleed that patient may have. There is many factors that affect the personalization of the prophylaxis in hemophilia patient. For example, age, body size, adherent to the treatment, somebody whom he is using his treatment as prescribed, somebody missing some doses every week. Genetic factor, it does affect the personalization too much. How frequent the patient does bleed, how bad is the joint, the access to the healthcare system, the physical activity, goals and need, coagulation capacity, and so on. Look into this slide with the clearance of the factor F and half-life. Usually, a younger age group, they have more clearance and subsequently a shorter half-life compared to the elderly hemophilia patients. In this example, some patient, the current or the previous regimen for the prophylaxis, we are using the same dose, the same frequency. So some people, they are underdosed and they need more. And some other people, they are overdosed and we are wasting our resources. So we need to readjust our doses according to each of them, according what I called it personalization. So we can save something. Look into this example. This patient receiving 25 international units per kg every other day. And this is his situation. Very good, fantastic, he is safe. Another patient whom he is receiving the same frequency, the same dose, but he has short factor 8 half-life. So this patient is at a risk for bleeding as is protected half of the time, and he is not protected in the other half. So during this period, this patient, he has low trough level and he may bleed. Although both of them, they are using the same dose, the same frequency, but they are different from each other. Optimization of prophylaxis doses depend on more than one factor. The treatment itself, the factor concentrate, effectiveness, safety, dose interval, peaks, trough levels, and so on. And the patient themselves, the body mass index, the weight, bleeding phenotype, activity, lifestyle, joint health, adherence, and most important, individual PK response for each of them. As I said earlier, probably 40 or 50 years, this is the timeline for the use of prophylaxis. But even when the people, they have started in early 70s with prophylaxis, they keep thinking about the personalization of the prophylaxis. Does the patient, all of them, they need the same dose, the same frequency, or we may change that, and the people keep studying this rationale, and this is 2 studies has shown that the use of the prophylaxis once weekly is different when we are using twice weekly or 3 times weekly. So they came with a conclusion that the more frequent infusion of factor 8 and 9, it will lead to better outcome. So some regimen came in 90s and early in the millennium, escalating either up and down. So people there try the best to personalize the prophylaxis. And I keep remembering, maybe I am old a little bit, if my brain function is still good. In 2012, the WFH has called for a meeting for hemophilia interest hematologists, and we have discussed this issue about the personalization in order to have better control of the bleeding, and maybe it will be more cost effective, and maybe we save more products. You know, the income in different countries is different. It is not the same. So now we are discussing, after many studies from that time till now, that personalization based on the BK is something good. So now we think about it, that why not to increase the trough level as far we could decrease the cost. And this came clearly in the recommendation of WFH 2020. The aim, of course, of the prophylaxis is to protect the joints from the bleedings and so on, though the aim now is to protect them from all type of bleeds and to keep them in normal lifestyles. But let me talk about the joint and chronic synovitis. Presence of the blood inside the synovium lead to inflammatory response and induced by the inflammatory and immune regulator pathway depend on the genetic variation. When I say that, that means not everybody bleeding the joint will have chronic synovitis. Some people, they bleed more than one time a year and they don't have chronic synovitis, while somebody, he bleed only once in life and he have chronic synovitis. And this depends on multiple factors, patient themselves, their genetics, their adherence to the treatment, and the adherence, again, depends on the healthcare system, the socioeconomics, how far they can get access to the therapy, and so on. When we talk about the adherence of patient to therapy, look into these graphs where we compare the age groups. The younger age groups and the elderly, they have better adherence to the treatment, while the matter is different for the young adults and adolescents, where their adherence to treatment is less. Subsequently, the bleed rate for middle age group is higher than the elderly and younger, and not the only factor is adherence, but there is some more factor for that. This is a study which is it's based on a questionnaire for the hemophilia patient families and healthcare providers. And this is the questionnaire. They are asking about the cost, the dose, the BK, the sampling, and so on. And they came with a conclusion that most of the patients, almost all, and 75% of healthcare providers, they are satisfied with the current treatment, but they are willing to change their regimen. And when we consider that preferred BK guide dosing, many of them, they agreed on it, but in most instances, they link the BK to the cost effectiveness and how far they can be and cost reduction and so on. So when they know that we may reduce this cost, they thought that this will be much better. How we go ahead with BK individualization for each patient. This is the care for the factor VIII clearance. And to know this curve or to draw this curve, we have to have samples, multiple samples, at different point of time. And we draw this curve to know the clearance, the volume of distribution, the terminal half-life, and subsequently, we know the individual BK for each patient, and subsequently, we know what is the exact dose and what is the frequency, whether we need to change our regimen in those patients or to keep the same when we change, whether we need to increase the dose or frequency or decrease the dose or frequency. There is three methods to determine the BK: individualized BK, population-based BK, and Bayesian BK estimation. This is one method of the BK calculation based on the ISTH recommendation or guideline, where we need to have a wash period. Then we need to do 11 blood samples over 2 days. And that means more visit to the clinic, getting nurses and staff more busy, patients have more samples, there is a wash period. So this method probably from the practical point of view is difficult. Then the ISTH guideline has been changed into 2 to 3 samples, at least 12 hours apart from them within 2 days, 48 hours with no wash period. And this is acceptable, and this is what we call it individualized BK estimation, based on a population BK estimation. Population, it is mean population, and then we compare the individual person with 3 samples to the population, and we came up with a conclusion of his own curve, and accordingly we can take care of his prophylaxis, and this method take care of the other factor like weight and age and so on. Then we thought, why not 2 samples, as far we are depend the individualization with the population, so we can get only 2 samples and we can draw the curve and know each patient what they are doing. This is individualization based on population BK curve. After that, we thought about something called Bhm Approach, where it is very complex calculation. It has been developed by Sir Thomas Bayes 300 years ago, not for hemophiliacs, but for other issues. It's a mathematical calculation and drawing of the curves and so on. So simply we can use an app with 2 samples. We submit those data, give us the curve, and we know where we are in treating this patient and what we need to do for that patient to change the prophylaxis or what to need to do. Cost effectiveness for the BK prophylaxis. This is a study. It's a small study, but they calculate the cost effectiveness when we base the prophylaxis on the BK compared to the standard type of prophylaxis. So as I said, it is a small study, and they compare those patients on prophylaxis BK and how costly is that. So I'm not going to detail of the result they have given to save more time for the discussions, but they have looked into the frequency of the prophylaxis, the bleeding by itself, and they calculate the lifestyle, calculate the how costly it is, and this is the cost for each one. So they have this cost for those whom they are using prophylaxis regimen, and almost 1/3 reduction when they use the BK prophylaxis method. This made the authors conclude, I read the conclusion, pharmacokinetic is unique to each subject and can help clinicians optimize treatment, improve the quality of life, reducing the infusion as well as the bleeding. BK driving prophylaxis can also decrease the cost of therapies, which are usually very high in hemophilia patients. So we thought that personalization of the prophylaxis for each patient, it will save money, it will save factors for us, particularly in this era where we are running short of factors. So we need to think about it in this way, that personalization of the prophylaxis based on the BK for each patient So we don't need to waste, and at the same time, we don't want to underdose our patient and they get at risk for the bleeding and so on. At the same time, we want to keep their quality of life as normal people as possible. Not only the joint, but they can do their sport. You know, many of our hemophiliac, they are cycling, they compete others, they win with prizes and so on. So we want this not only to be maintained, but rather to be much better in the future. Thank you.
Thank you, Dr. Tarawa, for this excellent speech. And now we will move to Dr. Hadil, our last speaker. Finally, Dr. Hadil Saleh, she is a pediatric hemato-oncologist at MPK Children's Hospital in Kuwait. And she completed her fellowship in hemostasis and thrombosis with the pediatric hemato-oncologist at McMaster University in Canada. And she will give a presentation in hemophilia prophylaxis. Dr. Hadil, welcome, and please proceed. Dr. Hadil?
Yes, just a second. I'm trying to share my slides. Sorry for that. Okay, can you see the slides?
Yes, it's clear.
Perfect. So good evening, everybody, and thank you for this wonderful evening. It's a fruitful information. It's my pleasure to participate in this evening with the most experts in hemophilia issues. Today, I'm going to talk about the prophylaxis in hemophilia. First of all, we know hemophilia is a lifelong severe bleeding disorder, especially without regular factor infusion, as we call it prophylaxis. So the standard of care of severe hemophilia is regular replacement therapy, which we call it prophylaxis, with factor concentrate or other hemostasis products to prevent bleeding, started early in life to prevent musculoskeletal complication from recurrent joint, muscle, subcutaneous, or even intracranial bleeds. Episodic or the on-demand clotting factors replacement therapy should no longer be considered to be a long-term treatment option. The implementation of home-based prophylaxis programs increases compliance and allow people with hemophilia to live relatively normal lives that need education of patients, families, and healthcare providers. The definition of a prophylaxis has conventionally been defined as the regular intravenous infusion of the missing clotting factor, factor 8, especially for people with hemophilia A, and factor 9 in people with hemophilia B, given in order to increase factor 8 or 9 level with the intent to prevent bleeding. The objective of prophylaxis has been to convert a person with severe hemophilia to a bleeding phenotype typical to moderate or even mild hemophilia by maintaining factor levels above 1% at all times. But this is an old definition for the prophylaxis. The new definition of prophylaxis with the advent of innovative non-factor replacement therapies, which for the most part can be administered subcutaneously, prophylaxis is being redefined as the regular administration, not only intravenous, but subcutaneous or otherwise, of a hemostatic agent or agents to enhance hemostasis and effectively prevent bleeding in people with hemophilia. Prophylaxis should lead to a healthy and active lives, including participation in most physical and social activities, whether at home, school, work, and also in the community. For hemophilia A or B with severe phenotype, including the moderate type of hemophilia with a severe phenotype, WFH had strongly recommends that such a patient to be on prophylaxis should be individualized and taking into consideration the following: patient bleeding phenotype, joint status, individual pharmacokinetic, patient self-assessment, and preference. Individualizing prophylaxis means that if patients continue to experience bleeds, then the prophylaxis regimen that they are on should be escalated, whether by the doses or the frequency, or sometimes by both of them. There are three different types of prophylaxis. We have the primary, secondary, and tertiary. I will start from the bottom, the tertiary type of prophylaxis, where it is initiated after the onset of a documented joint disease. And this is typically applied for prophylaxis commenced in adulthood. Whereas the primary prophylaxis, which is the regular continuous prophylaxis, started in the absence of documented joint disease, it's usually determined by physical examination with or without imaging studies, and before the second clinically evident joint bleeds and before the age of 3 years. Whereas the secondary prophylaxis, it's a regular continuous prophylaxis initiated after 2 or more joint bleeds, but before the onset of joint disease. And this is usually at 3 or more years of age. What is the benefit of prophylaxis? If we are talking about prophylaxis, we are talking about prevention of hemarthrosis and other spontaneous and breakthrough bleeding to maintain musculoskeletal health and promote a good quality of life for those patients. When prophylaxis is not visible, episodic therapy is essential treatment for acute hemorrhage, but again, it will not prevent long-term joint damage. So highly recommended to keep patients on prophylaxis. If we are talking about prophylaxis, we are talking about 3 options of therapy: either standard half-life factor replacement therapy, or extended half-life factor replacement therapy, or a non-factor replacement therapy. So let's start to talk about the standard half-life factor therapy. For the SHL, usually they are plasma-derived and recombinant. Both have a similar pharmacokinetic properties. The short half-life of the standard factors results in the need for frequent vein punctures, especially for those with hemophilia A, where they need around 3 to 4 times injection per week, and compared to the hemophilia B, where they need 2 to 3 times per week injection. Difficulty on accessing venous puncture that may lead to the need of central venous access devices in young children. And at the end, it will be very difficult to reach a trough level higher than 1%. And if this is the target, to reach above than 1%, then we might need a daily injection of those standard half-life injection. Through this calendar, we will talk about a patient who is hemophilia A on factor 8 standard half-life replacement therapy prophylaxis, where this patient might need a infusion around 3 to 4 infusions per week, equal to 15 to 16 needles being infused during this month. At the end, within a year, if we want to calculate the total injection or the total infusion or the total vein puncture, it's around 180 needles plus minus 5. We cannot make sure that the patient will receive the whole treatment because we have an issue with venous puncture. As we know, it's a difficult and it's a big challenge for the patient and for the caregiver. At the end, the whole calculation is to achieve a trough level between 1 to 3%. But what if we missed some doses or the patient had missed some doses? Whenever he missed single dose, that will expose the patient for a risk of bleeding. And I think the main issue with that is difficult vein access. And this is the main issue of the standard half-life factors. Compared to hemophilia B patient, where they are on standard half-life factor 9, though they are in need for a less injection, but again, having injection around twice a week, like around 8 vein puncture in a month, around 100 plus minus 4 vein puncture per year, again, the patient will face some challenges. And as we know, vein puncture is painful, especially for pediatric, also for adults, it's a painful issue. And can you imagine that patient will receive twice weekly dose injection? That will keep him, missing some days, some of those doses to avoid vein puncture. And whenever they miss any single dose, that will expose patient for risk of bleeding. So if we are talking about adherence to the prophylaxis and the patient or the caregiver, I think the main challenge is the venous access difficulties. Because of that, that will reduce the adherence to the prophylaxis, which lead to a reduced attached to the or adherence to the prophylaxis, and that will place the patient to risk of bleeding. Also, lack of comprehension on the part of the patient or the caregiver of the long-term complication of hemophilia, that will keep them reluctant to be adhered to the prophylaxis. The consequences of reduced adherence are reduced effectiveness of the prophylaxis, in which it will increase the risk of bleeding for those cases. So the main issue on treating our patient with hemophilia, whether A or B, is to maintain their prophylaxis in a less infusions matters by reaching a higher factor trough levels and to get another alternative, a non-IV administration or access. The second option of the therapy for the prophylaxis is the extended half-life, which came after the standard type. For the extended half-life factor prophylaxis, it showed some improvement in the half-life clearance with the dose and the frequency of dosing. Let's talk about the first part, which is the half-life of clearance. The current extended half-life for factor 8 had shown modest improvement of 1.4 to 1.6 fold in half-life clearance compared to the standard one. And by contrast, the extended half-life for factor 9 had shown greatly improved in half-life reaches to 3 to 5 folds longer. Regarding the doses, I think by having the extended half-life for factor 9 had showed more liable improvement in the doses, where the patient can reach a higher trough level with a once weekly doses of factor 9. Though the extended half-life factor 8 had similar recoveries as the standard half-life factor 8, and hence doses used for prophylaxis will be almost similar. Regarding the frequency, as I said earlier, for the extended half-life factor 9, as you know, we can infuse it once every 7 days or once every 2 weeks, and that will give a great trough level reach to 10 to 20%. So by less frequency of dosing with a higher trough level, I think we reach a good target on treating patients with hemophilia B as a prophylaxis treatment. So through the extended half-life, we have a less infusion, as we noticed through the factor 9, as well as we reach a higher factor trough level, reach to 10-29%, again with extended half-life factor 9. But still, we have the issue of venous access still there with extended half-life. So here we will talk about the non-factor replacement therapy, which is a well-known. Imicizumab is the most known one of the non-factor agents that do not replace the missing coagulation factor, but the good thing about it that we can apply it or administer it subcutaneously. It can be given weekly, it can be given bi-weekly, or even every 4 weeks. That will make things easier for the patient and for the caregiver. And even we can start the patient on a prophylaxis at an earlier ages without the need of central venous access devices, which improve the adherence for the patient and for the caregiver as well. And some of the studies had shown a 90%, more than 90% reduction in the bleeds versus the on-demand therapy. By reaching the imicizumab, we reached the point of a non-IV access by giving the medication subcutaneously. We exposed the patient for a less infusion because we don't need venous access, but we cannot say that we reach a higher factor trough level since we are not dealing with factors. But on the other hand, we are dealing with a less bleeding tendency for such a cases. So the basic requirements for effective prophylaxis will be through the following. We need a reliable, uninterrupted supply of treatment. We need consistent of expert monitoring through the clinical and the laboratory. We need a good patient adherence to prophylaxis, and we need the patient well understanding about the long-term benefit of having prophylaxis. And also we would like to encourage the home therapy by giving a good training for the patient themselves and for the parents and for the families and the caregiver who's taking care of those patients. I think by Mona Lisa, I reached my last slides. Mona Lisa is a piece of art that everybody admits on that. But in my opinion, medicine, again, is an art that deals with a very process of life. Looking forward for a better life and better outcome for the patient in general and for our hemophilic patient, where they deserve the best from us. Thank you for listening. I think I reached my end of the slides.
Thank you, Dr. Hadil, and such a very informative and clear talk, and thank you for this nice slides. And now we will start the discussion session. First question for Dr. Carmen. Dr. Carmen, as you mentioned that there is a different pegulated extended half-life, and each of them has a different molecular weight. Does this factor will affect your decision to choose one over the other?
So I clearly showed the benefits of a lower peg size, which is true for the Roriooctococc alpha pegol as well, partially for the Turoctococc alpha pegol as well. And these are particularly for small children. This is very important according to my opinion. Nevertheless, we also have to face the fact that even in GV, where a larger PEG molecule is attached to the Factorate molecule, we did not see any safety concerns yet. And we are talking about the group of patients, the pediatric patients, which have been treated in the frame of the study, as well as many real-world study data, including many patients of 12 years and older, and 12 years is still a pediatric patient cohort. So for me, yes, the PEG size matters, and is therefore for myself, for my decision, important when I'm using a pegulated molecule in children.
Okay, there is a question from Dr. Muhammad Ansari: how to prepare a patient for a major surgery on prophylaxis with non-factor treatment? I think this is out of our lectures, but if you would like to comment, Dr. Carmen.
Yes, so for a major surgery, it depends whether I'm talking about a patient who is treated prophylactically or on demand. In any case, for a major surgery, it is extremely important that I exclude any inhibitor development. So before a major surgery, an inhibitor test is mandatory. And by the way, when I'm treating patients with Factorate products, I can use standard methods, such as the one-stage clotting assay, which is not the case anymore if the patients are treated with a non-replacement therapy. Here I have to use the bovine chromogenic method. And then I have to do a cautious plan to prepare the patient, to write a substitution plan for the surgery and a plan for the ward when Factorate, respectively Factor 9 levels, should be checked, preferably daily. And here I would recommend to follow the WFH guidelines concerning the trough levels.
Dr. Carmen, thank you so much for your presentation. I have a question on the same field, that you're talking about patient who is on non-factor therapy with non-inhibitors. But what if the scenario became different, that we have a patient who is on having inhibitors and he's currently on a non-factor treatment with a bypass agents in between? So would the scenario be the same for surgical preparation?
So the scenario is similar. So if I'm talking about an inhibitor patient, particularly before a major surgery, I should definitely know the inhibitor titer. So if the patient having a high titer inhibitor, in this case, I can exclusively use recombinant factor 7A without any harm. We know that the concomitant use of APCC together with emicizumab poses the patient, particularly when I'm using it at regular doses, regular intervals, I'm posing the patient at a high risk to develop thrombotic complications, including thrombotic microangiopathy. However, if the inhibitor is a low responding one or has become even negative during the emicizumab prophylaxis, I have the unique chance to use Factorate in this patient for a certain period until an amnestic response occurs. And I think this is extremely important for a major surgery if the patient does not satisfyingly responds to recombinant factor 7A.
Okay, thank you so much.
I have a rescue therapy with Factorate then, but then I need the lab with the bovine chromogenic assay in the background. If it is a non-inhibitor patient, I need the lab as well, because I have to monitor Factorate, which is administered in the setting of this surgery.
Like my question came from a real case that we are facing nowadays. It's a complicated little bit case, 6 years old with inhibitors and resisting to many treatment. He have been on imicizumab for the last 2 years and still on the bypassing agent as well. And recently, I think he's showing even resisting to the imicizumab, where he is still continuously have bleeding episodes with minimal, injuries. He's on a weekly imicizumab, and his titer of the inhibitors is risen up, reaching 400 nowadays. So just came to my mind, what if he exposed to any emergency or any surgical emergencies? Yeah.
So if you observe a patient under regular treatment with emicizumab still experiencing numerous bleeds,
he was stable, and recently he experienced this.
Okay, so if he continues to have these breakthrough bleeds, which are not expected in this situation, you have to look for neutralizing antibodies against emicizumab. These have been described. This is absolutely rare, but it might occur. So if you see a lacking efficacy in the presence of emicizumab, my personal first approach is to look for emicizumab concentration. There might be a lack of adherence in the patient as well. And if emicizumab levels are in a normal range, that you should be on the safe side. But however, if emicizumab levels are extremely low, the reason for this might be lacking adherence or a neutralizing antibody, which might be transient or persistent, but then you have to go a little bit deeper on that.
Yeah. Thank you so much.
With pleasure.
Dr. Carmen, there is a question for myself. Is there any reason why the none of Pegulated extended half-life product have been approved by the EMA?
So there have been animal studies which showed an deposition of PEG in the plexus choroideus of these animals. However, we have to face the fact that these, first of all, are studies in animals, and second, those animals have been treated extremely intensively, including extremely high doses. Nevertheless, so this was one of the drivers of the EMA not to license these products in the very young children. Nevertheless, if you look at the worldwide perspective, first of all, you see that in clinical studies, there were no safety issues. And second, you can see that these products are used worldwide out of the EU, even in patients below 12 years of age without any safety issues. So in conclusion, I'm really looking forward that this will be changed after in a certain time. What is also remarkable, our neighbor country, Switzerland, which is not in the European Union, they are able to treat, and they treat pediatric patients with Pegulated, Factorate, and Factor IX products. So, yeah.
Thank you, Dr. Carmen. The next question for Dr. Tarawa. Do you expect any challenges in if you implement the personalized prophylaxis? And do you think the digital tools, as you mentioned, will support the patient in personalization?
I think yes, personalization of the, or individualization of the prophylaxis for hemophilias. Now it's a recommendation. We need to do it. I know most of the countries, they are not following this recommendation, but I think we need more studies, of course, to convince people that this is better from the cost point of view, and it is better from the saving more factor concentrate for all people. But personally, I believe that this practice should be the case for all of our patients. Myself, I am following this recommendation.
Okay, thank you. There is an anonymous attendee that he is asking, are there any chance of thrombosis if overdose on the replacement therapy of factor VIII? Dr. Hadi, can you answer him?
Sorry, I didn't catch the question.
Are there any chance of thrombosis if overdose on replacement therapy of factor VIII?
Could be. Could be. Still, the risk is there.
Okay. And do you think that the higher level, trough level, more than 1%, should be recommended for the hemophilic patient to have ABR around 0?
Well, according to the WFH guidelines, which was published in 2020, the target now is to reach a target level of 3 to 5%. It's not anymore 1 to 3%. They are looking forward for a higher trough level.
Maybe I can add the experience from Germany. So one of our largest centers, the Bonn Center, performs prophylaxis since decades, and they perform, let's say, a high dose prophylaxis, and patients were always above 1%. Nevertheless, long-term evaluation of the joint status revealed the development of arthropathic alterations at the age around 20 to 30 years of age. So the patients had mostly very few or no breakthrough joint bleeds, but the fact that they had a trough level of 1% did not seem to be sufficient to prevent them from the development of hemophilic arthropathy. And taking in account this, this led to the fact that the WFH, including many other local instances, recommend a trough level above 3 or 5%. Potentially, we need even higher protection. We still do not know. I think the whole thing is under investigation, and I think with the availability of extended half-life products, we have a unique possibility to make these high trough levels reality, because with a standard half-life product, this is extremely burdensome for a patient, because with that, a patient has to do a very strict every other day injection of a factor VIII product, and this is quite cumbersome.
Yeah. So we are looking for more than 3 to 5% trough level, right?
Potentially, yes.
Yeah, yeah. Hopefully we reach it.
Can I add something to this, please? For a second.
There is some recommendation by some other organization, a part of WFH. They may ask for higher level, even 8 to 12%. And personally, I believe that, again, personalization will answer this issue. It's quite difficult for many countries to go for this level, like 8 or 10% or so. But as Hadir said, the WFH recommendation, it is 3 to 5%. It has been changed from 1 to 3%.
I mean, the 8 to 12% is something that came from the PROPEL study that was performed on Rureoctococc alpha pegol and was published recently. And it showed better outcomes when you exceed the 3 to 5%, going to this on average 10%. So that is a clear hint into that direction. And the recommendation by WFH not only says 3 to 5%, it also calls for personalized prophylaxis. meaning that you should adjust doses according to the individual needs of the patients, and that could, of course, count for higher trough levels.
Doses and the frequency.
Right.
Yeah.
Correct.
Okay. So, thank you, Dr. Carmen, Dr. Peter, Dr. Tarawa, Dr. Hadil. And at the end of our meeting, if any of our eminent speakers would like to give a final statement before we close, please go ahead.
Thank you, everybody. Dr. Carmen Hadil from Kuwait. She is very busy, but she could make it and participate with us. Thank you, Hadil. Thank you, Carmen.
You're
Thank
most welcome.
you, Ahoud, for late communication, and you could make it too. Thank you, everybody.
Thank you.
And once again, I'd like to thank Saudi Society and Takeda for organizing such a pleasant meeting, and everyone has a good night.
Thank you.
Thank you, and stay safe and sound.
Yeah.